disclosures. All right, so managing chemotherapy side effects, and this is with Michelle Gardiner, PharmD, BCOP, CPP. Michelle, welcome. Thank you so much for being here today. All right, and Michelle, I'm for some reason I'm having a bit of a hard time hearing you. Let's try that again. I'm not sure what happened.
Oh, is that better?
That's much better. Thank you. Okay, good deal.
I wasn't speaking loud enough. Okay.
Oh, no. Oh, good. We've got you now. So, so Michelle, a clinical pharmacist practitioner in the Adult Oncology Infusion Clinic at the NC Cancer Hospital. Primary role is educating patients on appropriate management of expected side effects from chemotherapy treatments and ensuring that patients have the access to the necessary medications for best self-care at home. And you've worked as a pharmacist at UNC Hospital for 13 years. What else should we know about you? Do you anything to round that out? And hobbies, travel? I know we're not doing a lot of that now, but
no, I had to cancel some trips. Thank you, COVID.
Yeah.
But yeah, no. I have 2 kids and a new dog. Also, probably because of coronavirus, this is why we got a new dog. And
well, congratulations on that. Yeah, my virtual backdrop here is the Canadian Rockies, which is where I was supposed to have been up until a couple of days ago.
Yes.
So where is you're right on campus there outside in the.
Oh yeah. This is actually my husband took this photograph.
Oh, nice. Well, it's a great photo.
Yes.
So, all right, so let's see. And the question, the poll everywhere question, cancer patients never have reactions to any chemotherapy regimens. And if you think that that's true, you can go ahead and mark that as A. If you think that's false, you can go ahead and mark that as B. And whoops. And while we're waiting for those answers to roll in, this activity has been, it has been planned and implemented under the sole supervision of the course directors in association with the UNC Office of Continuing Professional Development. William Wood, MD, MPH, and CPD staff have no relevant financial relationships with commercial interests as defined by the ACCME. Michelle Gardiner, PharmD, BCOP, CPP has no financial relationships with commercial interests as defined by the ACCME. Got it. All right. Does that fairly cover our disclosures, Michelle?
Yes.
Okay. I'm not too surprised, but we seem to be kind of running heavily in that false or B answer, which I'm guessing means that we have a good premise for your lecture today.
Okay, good.
Okay, awesome. Great. So managing chemotherapy side effects, reviewing prevention and treatment strategies of 3 common issues with Michelle Gardiner. So thank you, and Michelle, take it away.
All right, thank you very much. Okay. All right, so yes, I work in the infusion clinic at UNC. I've been remote since, coronavirus, but I've been there for over 5 years, and there's a lot of just managing the day-to-day stuff and seeing patients as they come in either the first time they get treatment or as they repeat. And some patients are with us for years. So a little bit, we're going to talk about these 3 topics. Some are acute and some are more like a chronic issue. So objectives. So by the end of this, hopefully you'll be able to identify tactics for preventing and treating acute infusion reactions. You should be able to describe some non-pharmacological and pharmacological ways to prevent or manage chemotherapy-induced peripheral neuropathy. And demonstrate an understanding of cancer-related fatigue and treatable contributing factors. Okay. All right. Next slide. Okay, thank you. All right, so these next terms I'm going to use sort of interchangeably. There's an infusion-related reaction, which is IRR, and hypersensitivity reaction, or HSR. And the characteristics of these things are that they're acute, like meaning they happen less than an hour after the infusion is done. Some of the common things about them, there can be itching, pruritus. Typically it's concentrated, or I find that it's concentrated in like the ears, or the throat gets scratchy, or people's scalps get a little itchy, more so than like all over body itching. It's usually concentrated more in the face and the head. There can be flushing, like they turn red. There can be hives that actually people start to break out in hives or rash during the infusion, shortness of breath, bronchospasm, sense of chest pain or tightness. Some people spike their temperature, get a little fever. That can be rigors or chills. Hyper or hypotension. Back pain is a thing that a lot of patients can experience. And then also like weakness or a headache or just a general sense of wrongness. I've been talking to patients and just they are like, something's not right, you know, even before anything can be seen outwardly, right? So those are just some things to keep in mind about what these look like. Okay, so we're sort of going to concentrate on focus on a small group of well-known medications with reputations that are causing some hypersensitivity reactions or infusion-related reactions. So the taxanes, Abraxane not so much, but I put it in there just for comparison's sake. About paclitaxel and docetaxel definitely. The platinums, especially cisplatin, carboplatin, oxaliplatin, and then CETUXIMAB and RITUXIMAB are the monoclonal antibodies we'll focus on today. There's other neoplastic agents that I'm sure anybody who's worked with cancer patients has experienced them. So etoposide or other monoclonal antibodies like trastuzumab or daratumumab are also known to cause infusion-related reactions, but we're not going to talk about this today. I had to limit the scope a little bit here. Okay, I think if you could skip forward 2 slides, please. Next one, yeah, thank you. Okay, so when we talk about infusion-related reactions, you could divide them into 2 separate groups. So there's type 1, which is like a true allergy. It's IgE mediated. It's usually associated with the repeat exposure, if not to the medication itself, to something that sensitized someone to a patient to the medication. It results in a release of antihistamine, of histamines, prostaglandins, leukotrienes, can lead to the contraction of smooth muscle and dilation of the capillaries, leading to hypotension. There could be urticaria, rash, and bronchospasm. The other type of infusion-related reaction you could see would be what could be termed as an anaphylactoid or pseudoallergy. And this is not an IgE-mediated process. It frequently occurs on the first and or second exposure to a substance, and that substance or the medication, the metabolite, or the solvent can interact directly with mast cells and basophils to cause a cytokine release, and versus the type 1 where the IgE is the thing precipitating the reaction. Okay, but for anaphylactoid, it doesn't require there's no immunoglobulin, there's no IgE that's causing these reactions. Okay, but they can look similar. There's a cytokine release, and they can also have things like hypotension, rash, bronchospasm. Okay, so in the moment, the infusion-related reactions, the symptoms are treated the same. It doesn't matter if you would later call it a type 1 or anaphylactoid. It doesn't matter. The mechanism of the reaction, it doesn't matter acutely. You're just trying to manage the patient's symptoms. Okay, next slide. All right. So this is just something the NCI, the National Cancer Institute, the Common Terminology Criteria for Adverse Events, CTCAE. This is version 5.0 from 2017. And this just defines what an infusion-related reaction is and the grades that they're giving to it based on the symptoms. So the grade 1 would be a mild transient reaction, infusion interruption not even potentially indicated, intervention not indicated. I will say that an example of that would be someone can be turning red, like flushing from their medicine. Yeah, I'm going to stop that medicine. I'm going to interrupt the medicine, and probably if it's a phase 1, oftentimes the person will just, as soon as they stop the exposure to the medicine, that immediately their color returns to normal or their symptoms stop. So still usually, even if they're recovering, I might still give at least like diphenhydramine, 25 milligrams IV before re-challenging them or before restarting the medicine. And then grade 2, an example of that would be flushing, itching, rash. It subsides once infusion is stopped and usually also requires an administration of an antihistamine and or corticosteroid. Okay. And the prophylactic medications indicated for less than 24 hours. Often it's just immediate right there in the clinic, and their symptoms resolve within 30 to 60 minutes. And usually you can do a re-challenge at the same time. Once you get to grade 3, we're looking, that's pretty serious. The recurrence of symptoms following initial improvement, that can be scary when you stop the medicine, you give the people the emergency medications, and then they seem to be doing better briefly, but then all of a sudden the symptoms come back even without re-challenging. And then grade 3 or 4 could involve like, grade 3 could involve epinephrine, grade 4 definitely probably will, maybe even intubation and a stay in the ICU. So we definitely want to avoid those things. Okay, next slide. Okay. So since infusion reactions happen acutely, and while more expected with certain medications, they're ultimately unpredictable. So there should be standing orders available to implement immediately. And nursing should be able to access these medications or interventions without needing a newly written order from a provider. Okay. At UNC, we use diphenhydramine, famotidine, methylprednisolone, and like epinephrine. They're part of what's called a hypersensitivity group of medications. They're available in the Pyxis machine. You go to the Pyxis machine, sign in, select the patient, type in hypersensitivity, and all these medicines pop up. You can select what you want, and the drawers will pop open in the Pyxis, and you can pull them out, so you can get them very rapidly. I know that other institutions sometimes place all those medicines together in a type of kit that if you access your medication, dispensing machine, Pyxis, whatever, you can somebody could pull out all those supplies at once. Okay. In addition to those medications, oxygen needs to be available for people if their SATs are especially dropping below 92 in here, or they're having trouble speaking. And then a bolus sodium chloride order, also for dropping for hypotension. And meperidines on here in case of mostly for rigors or chills. Okay. And then epinephrine, of course. We hope we never have to use that, but you definitely want that on your emergency order set readily available. Okay, next slide. All right. So let's just start with the taxanes, okay? So primarily paclitaxel and docetaxel. Their reactions are considered primarily anaphylactoid, meaning they're not true allergies. Usually occur with the first or second infusion. The thought is that it's likely due to the solvents that are used to prepare these medications when they're manufactured. So paclitaxel utilizes Chromophore EL, and docetaxel utilizes polysorbate 80, and also a type of alcohol is involved in the docetaxel as well. Because of the risk of infusion reactions, the package inserts of both paclitaxel and docetaxel have specific pre-medication recommendations. We do pre-medicate at UNC. We definitely use the corticosteroid, and we use antihistamine H1 and H2 given 30 minutes before treatment. Diphenhydramine, at our institution, it can be dexamethasone 20 milligrams IV or PO, diphenhydramine 25 milligrams IV or PO, and famotidine 20 milligrams IV are standard pre-medications for paclitaxel given 30 minutes ahead of time. And then several years ago, there was a very serious shortage of famotidine IV. So we were using famotidine 40 milligrams PO or orally 60 minutes before the paclitaxel, and that also was effective. The docetaxel package insert states that it depends on how you're using the docetaxel or what regimen you're using it with. But the package insert states that patients should get dexamethasone 8 milligrams twice daily, the day before, the day of, and the day after. So the day before and day of is primarily to prevent infusion reactions, and then the day after is to prevent fluid retention or edema that can occur. And then if somebody's got prostate cancer, they would give them 8 milligrams 12 hours before, 3 hours before, and then maybe 30 to 60 minutes before, okay? Because they're also taking prednisone if they're a prostate cancer patient. However, I will say at UNC, a group of providers, some of them do not give any extra dexamethasone to patients. We're not doing that before and after treatment anymore. Instead, they're just doing the 8 milligrams orally 30 minutes before the infusion, primarily meant for just, anti-emesis, so people don't have nausea or vomiting. And so far, so good. We haven't seen an uptick in reactions from this reduced use of dexamethasone, which I think is important because, one, it's on shortage right now, and two, a lot of patients just do not like to take the extra steroid because of the side effects. All right, there is no, if you can look at my slides, I really couldn't find information about specific cross-reactivity between these medicines. But the rate of reaction can be pretty serious. So paclitaxel, the rate of hypersensitivity reaction is anywhere between 31 and 45%, with severe reactions in 2 to 4% of people. And taxanes, it says rate of hypersensitivity reaction for Abraxane is 4%, but I've never seen a serious one. And then for docetaxel, the rate of hypersensitivity reaction, 6 to 21%. Okay, let's talk about, next slide. Okay. So paclitaxel and docetaxel rechallenge. So the choice of if and when to rechallenge kind of depends mostly on the severity of the reaction and the patient's willingness. If the patient is completely anxiety-ridden after just some flushing and itching, and they don't want to continue, obviously you're not going to continue. But if a grade 1 reaction or possibly grade 2, you may be able to just give the antihistamines like the diphenhydramine, famotidine, and or the corticosteroid like a methylprednisolone in the clinic, and then restart the infusion at half rate. Okay, so most common paclitaxel doses at UNC are 1 hour. That's most of the regimens we're seeing these days. So it's not a major time concern to increase that rate to 2 hours. But more of a logistical issue if you were trying to give a 3-hour paclitaxel infusion. You might want to try to titrate that slowly so you're not running at 50% rate and making it a 6-hour infusion the full time. Okay. As far as like how to handle it, if you're going to bring them back another time to rechallenge, there's a common strategy used for lots of allergies. Where you would give a steroid, like before, like a few doses before they even come into the clinic. So you could try 20 milligrams, 12 hours, and 6 hours prior, maybe increase the antihistamines, like have them take, Zyrtec or Claritin or Benadryl at home the night before, the morning of, and then of course continue your standard pre-medications ahead of time. And for a lot of people that will work. That'll be sufficient for them to get through the process and be able to continue therapy without a reaction. Okay. So what about the tolerance of NAB-PACLITAXEL or Abraxane? In that sense, like nanoalbumin-bound paclitaxel. So the big thing about this is it has no solvent. It's just a powder that's reconstituted with normal saline. So it has no polysorbate 80. It has no chromophore. And so specifically to find some information about because I know that we do this all the time. I know that people react to paclitaxel, and okay, and sorry, I got distracted by the chat. Something going on in the chat. Okay, this article is about 37 patients at one institution. They were all GYN patients. And all of them had a history of a reaction to paclitaxel, and 6 of them had a reaction to paclitaxel and docetaxel. So and this was where all those doses were appropriately pre-medicated. So it's not like the patients didn't get all their recommended pre-medications and then they reacted. No, they reacted even though they were appropriately pre-medicated with antihistamines and corticosteroids. Okay, so in the case of docetaxel, they even went above and beyond the package insert recommendations for the corticosteroids with the antihistamines because that's not in the package insert. And then when they challenged them on the NAB-PACLITAXEL or Abraxane, all of them did fine. The first 3 doses of the Abraxane were given with the dexamethasone 10 milligram IV pre-medication 30 minutes ahead of time before the infusion was started, and then they stopped it unless it was needed for nausea prevention. I will say at UNC we don't even use dexamethasone as the pre-med for Abraxane. It's considered low risk for nausea, so we usually just give Zofran as the only pre-med. Okay. All right. Next. Okay. Other way. Next one. Okay. All right.
Sorry about that. My mouse has a mind of its own today. So let's see. Let's get you on the right slide here.
So one more, I think.
All right. It does not want to stay on that slide.
One more. Again.
Right there.
Nope, one more. I did that one. Okay, yeah, okay. All right, thank you. So platinum-based chemotherapies and hypersensitive reactions. So, you know, platinum, oxaliplatin, cisplatin, carboplatin, the most important thing about this is it's primarily an IgE-mediated, meaning it's considered a real allergy because it occurrence increases with increased exposure. So as people, repeated exposure to the medication results in the true allergy to the medication. The occurrence of a reaction increases over time, with the most infusion-related reactions occurring somewhere between the 5th and 8th dose. And then the infusion-related reactions can increase in severity over time. So a grade 1 reaction that responded to an antihistamine and or corticosteroid, and then the patient tolerated the rest of the dose of a slower rate, like if they had a reaction in clinic, then the next time you try to bring them in, and even with extra pre-medications, you might get a grade 3 reaction, resulting in several hours of vital sign monitoring. So whether or not to continue the a platinum-containing medicine after they've had a reaction to it is you know, a kind of a serious decision. So the usual choice is you can either stop giving the platinum and go to something other type of therapy, or if it's really important, like that they get the platinum, you could attempt a desensitization. At our institution, I know the GYN ovarian cancer patients are the ones most likely to do carboplatin desensitizations, and for other solid tumors, we typically just move on to a different type of therapy or remove the platinum. In the case of like a GI cancer patient, who's getting like FOLFOX, then they might just stop oxaliplatin if they've gotten enough doses to either be considered, you know, appropriate for curative intent, or if they're metastatic, there's other options out there if they want to continue treatment. They don't have to get a platinum. Okay, and so that's up to the oncology team. All right, the attending and the APPs. All righty, next. Next one. Okay, rituximab. So exactly like what's called HSR to or infusion-related reaction to rituximab, you can see it's anywhere between 12 and 77%, depending on where you looked for that information. And that's primarily with the first dose. And the occurrence of it does decrease with subsequent infusions. So those are some of the common side effects: the itching, the hives, shortness of breath, flushing, hypertension, rigors. So just know that like why that is happening is mostly related to just the first time exposure to the monoclonal antibody, but there's a few ways you can predict who's more likely to have an infusion reaction to rituximab. So next slide. All right, so patient characteristics that influence the occurrence of a hypersensitivity reaction. If the patient has bulky disease, greater than 10 centimeters with their initial exposure, for most patients, the reaction is only with dose 1 and occasionally with dose 2 and beyond. The majority of patients only experience the 1 reaction with cycle 1, and they can be titrated to maximum rate after receiving their HSR medications. However, sometimes there's a second reaction when the titration is attempted. And so the patients who fall into some of these categories, such as the bulky disease greater than 10 centimeters, indolent subtypes of lymphomas specifically. So instead of an aggressive lymphoma like diffuse large B-cell lymphoma, if they're coming in and being treated for mantle cell lymphoma or a follicular lymphoma, then they're more likely to have a reaction to the rituximab the first time they get it. And then also if they have high levels of circulating tumor B cells, which you will see more often in things like chronic lymphocytic leukemia as opposed to just a straight lymphoma. But I know if a CLL or chronic lymphocytic leukemia patient comes in and their lymphocyte count is 80,000, the chance of them having a reaction is pretty high. All right, and that's also that explains also why when they come in for their second infusion, they're way less likely to have a reaction, because now you've reduced the bulk of their disease, you've reduced the levels of circulating tumor B cells, and so they typically do much better on their second and third. All right, So strategies for managing the hypersensitivity reaction. Obviously, you interrupt the infusion, you stop it, you give your medications. Usually we just go ahead and give the antihistamines and the corticosteroids because reactions to rituximab occur within the first couple of hours after starting. And if you're titrating, you're only going to be at like 150 milligrams per hour or 200 milligrams per hour in a 700 milligram dose. And you have, you have quite a ways to go. So we'll just give all the 3 major medicines to treat the hypersensitivity reaction. Patient feels better. We restart at half the rate of whatever they were when they reacted and keep titrating from there. However, sometimes there's a second reaction when you attempt to titrate up past where they reacted last time. And for most patients, it's okay to give another round of antihistamine, like another 25 milligrams of Benadryl, another dose of methylprednisolone, and then probably would choose not to titrate after that because we don't want to keep having to give Benadryl and methylprednisolone. It's taxing and anxiety inducing for the patient. Somebody typed in here for a previous infusion reaction, do we utilize the Ativan? Yeah, if the patient's super nervous, yes, we might add that. If anxiety is contributing to some of the sensation of this isn't quite right and they're nervous and it's obviously, affecting their ability, to be there and complete their therapy, then if the patient's okay with it, we might give a little Ativan just to help them calm down and relax about the process. Because if somebody's already nervous when they're coming in for the first round of chemo and then you give them something that's making them react, especially more than once, that would really make them nervous. So you have to try to calm them down. And then, so if someone's reacting multiple times to the rituximab and you decide, okay, we can't keep titrating it, then to finish a dose that may require admission for the night, or sometimes the provider may just decide, like, okay, run it at that rate for the duration of the clinic day, and then when everyone's ready to pack up for the day at the end of the night, we can just stop and the patient gets what they get, and knowing that next time when they come in, they'll probably tolerate their full infusion with no issue. Okay. Therapy for brain tumors. I got a question here. I'll come back to that because I see if I have an answer for that later on in the program. Okay, so rituximab. Alrighty. Next one. Okay. So CETUXIMAB. All right. ERBITUX. All right, so anybody who's in North Carolina is probably, and working with oncology, is probably very familiar with the story of ERBITUX, okay? So it's an EGFR epithelial growth factor receptor antagonist and used in head and neck cancers and metastatic colorectal cancers, okay? So in the initial FDA approval, they had a grade 3 and 4 infusion reaction in less than 5% of patients. So pretty good. But then in the southwestern United States, including North Carolina and Tennessee, they saw grade 3-4 reactions of greater than 20%. So quite a difference. And then it was discovered, some very smart people discovered that the reason for that is preformed immunoglobulin E antibodies against the galactose alpha 1,3 galactose in the serum. Okay, so that people already were sensitized. But they had not gotten cetuximab before. They were sensitized. And they were sensitized by tick bites. So exposure to tick bites, specifically the Lone Star tick, increased, people developed what's called alpha-gal in their, antibodies in their bloodstream, and that made them more likely to react to the cetuximab, right? So there's a study here published in 2016. You can do an alpha-gal assay for IgE antibodies now. It's considered negative if its reading is equal to less than 0.10 kilounits per liter. And the study included, they were going to go ahead and give people cetuximab as long as their alpha-gal levels were less than 0.35 kilounits per liter. Okay. In the study, they 37 of the 60 patients that they, or 61.7% of the patients that they screened were negative for alpha-gal, meaning their levels were either reading at less than 0.10 or up to 0.23, and they treated them with cetuximab and they had no anaphylaxis. 38.3%, 23 out of 60 patients were considered positive, and the range of values in those patients were anywhere from alpha-gal level of 1 all the way up to 44.2, which is quite high, and they were excluded from the CTCAE arm. Okay, so in the package insert, alpha-gal testing is not mandated. Instead, they suggest that you look for things like evaluate for a history of tick bites, and that you also look for a history of red meat allergy, because tick bites are also what give people this red meat allergy where they can't eat any meat that came from an animal with hooves, like cows, lamb, pig. So if they have those things, they're likely going to have a positive alpha-gal, which increases their likelihood of having a potentially very serious reaction to the CTCAE. Okay, we do this at UNC for all of our CTCAE patients. You do have to plan ahead for it. It is for us, it's a send-out test. And it takes 7 days to get the results back. So, you know, it has to be ordered and drawn and sent off at least a week before you want to give CTCAE. And also in the package insert, they recommend pre-medicating with antihistamines and corticosteroids. And we still do that at UNC, 20 milligrams of dexamethasone, 20 milligrams of famotidine, 25 milligrams of diphenhydramine are our standard pre-medications. But I think this has been a lifesaver for us, because we used to have one-to-one observation for all of our patients who were starting CTCAE, a APP or a fellow or the attending had to come up and sit with the patient for the first 15, 20 minutes of every initial first CTCAE, which is quite a lot of, you know, time away from clinic for these providers. And just to make sure there wasn't going to be a reaction. And then the reactions could be very, very serious. You know, people had to go to the ICU because the reaction was just so intense and required epinephrine, and their SATs were very low. And yeah, so it's been amazing that we can not have to do that anymore. Okay. Oh, I'm sorry, I forgot to have you move the slide up. Sorry, there we go. There's the study information. So one thing that was a limitation on this study was that they only took people up to 0.35 alpha-gal, and so the wondering is that could you safely treat people that maybe had a higher alpha-gal, that were positive, like they had measurable alpha-gal, but maybe you could go up to 1, maybe you could go up to 1.5. So that might need to be checked, but I don't know if the packagers or the company's ever going to do that, because the issue is really concentrated in the southwestern United States, and other areas of the country aren't having the same risk with these tick bites and positive alpha-gal and CTCAE reactions. Okay, next slide. Okay, so we talked a little bit about okay, these are examples of medicines that can have a reaction, and how to maybe, for some of them you can predict it, you can kind of get an idea of who's more likely to react with rituximab. You can do alpha-gal testing, or even at least screen for the tick bites or red meat allergy for CTCAE to see if they're going to react. You can kind of get an idea. You maybe watch your patient a little more closely if you're on cycle dose 5, 6, 7, 8 of platinum. You know, for trying to see if they're going to have an actual reaction. But if they have a reaction, you decide to treat, and they don't respond to just like half rate or whatever, you can actually do a drug desensitization. And there's several articles about this in the literature, various sizes, various drugs, like various strategies. A lot of the articles reference doing things like skin test and intradermal testing. I did not go into that because I find that would be highly just problematic and an issue for accomplishing skin testing in any large capacity at a big center like we are. We just don't, the amount of manpower it would take to create chemo orders, to order this thing, to pull, you know, the pharmacy has to pull up 1 milliliter of drug to be given to the patient, and then you have to be observed. I don't think that's practical. So anyway, there's several different desensitizations. A common one will include like, one of the most published strategies involves three solutions made up of increasing concentrations of the medicine that you're going to desensitize to, and then each bag of solutions being titrated in 15-minute increments. It involves up to 12 steps, and then, you know, at least 3 bag changes. And then I came across this as a rapid drug desensitization. And I thought this was very practical and potentially very useful in an outpatient setting, especially. You heavily pre-medicate your patients, and then you use one bag of solution. The total dose is stuck in one bag, maybe slightly more dilute than normal. In this study, they used 500 ml total volumes for platinums, taxanes, and rituximab, and 250 mLs for CETUXIMAB. And then they pre-medicated heavily with so they gave them cetirizine, which is Zyrtec, every 12 hours for 3 days beforehand. They used aspirin in this study unless it was contraindicated. We might use Tylenol and at UNC if we were going to copy this. Singulair or montelukast, especially anybody who had some sort of underlying asthma issue or COPD, or who had respiratory issues when they were exposed to the medicine. The dexchlorphenyramine, which would be like diphenhydramine, and 30 minutes beforehand, ranitidine 50 milligrams IV beforehand, or famotidine 20, same thing. Their corticosteroid that they used was either methylprednisolone at 1 mg per kilo or hydrocortisone at 100 milligrams IV. If they were getting rituximab, they would do that. And then they would also give dexamethasone 20 milligrams orally 12 hours and 1 hour before. So heavily pre-medicated patients, all right? So they did that, and they were pretty successful. This particular study had 490 different desensitizations in several patients, and most of them tolerated quite well. So here's just an example of the rapid drug desensitization. It took 3.5 hours to complete, and there's no bag changes. This is for oxaliplatin diluted in, put in a 500 ml bag of fluid. It still requires intense nursing involvement with rate increases every 15 minutes for the first 2 hours, but it would be a more efficient way to achieve a desensitization within an outpatient infusion clinic. But you can't, your team still has to, everyone has to be aware. Your infusion clinic would have the staff nursing so that they could be one-to-one with the patient. You can't just be like, oh, by the way, we're doing a desensitization today. You can't just spring that on your people. But to me, this is the best strategy I've seen, and I would, if we have an opportunity to do this, this is what I would try for a patient going forward. Okay, next slide. Okay, take-home points. Hypersensitivity reaction, infusion-related reactions are unpredictable. Predicting infusion-related reactions may be possible in cetuximab and rituximab. You should have a standing hypersensitivity reaction response orders in place if you're using any of these infusions. Consider enhanced pre-medication strategies and slower infusion rates if someone does have a reaction. Discontinue the precipitating medication if you can't make it better. Change the treatment where appropriate, and consider desensitization when discontinuation or changing the treatment not an option, and or expected future treatments are limited. If you know you only have to get through a few more doses or something, desensitization might be worthwhile if it's for curative intent. Okay, next one. Pull everywhere.
All righty. So just a reminder to everyone, these are completely anonymous, and so we encourage everyone to go ahead and take your best shot on these.
You want me to read it?
Sure.
Okay. So JB is receiving oxaliplatin as part of her FOLFOX regimen for metastatic colon cancer. She tolerated her first 5 infusions without issues. 15 minutes into her 6th infusion of oxaliplatin, she experiences chest tightness and shortness of breath. The infusion is stopped and she receives IV antihistamines and IV corticosteroid. Her symptoms resolve after more than 1 hour. So.
All right. And so now we've got 4 different choices. You can say patient patient should receive future oxaliplatin doses only with a desensitization protocol. B, no special management is required as this reaction is unlikely to happen again with future doses. C, oxaliplatin should be omitted from future treatments as risk is greater than benefits. Or D, I'm not sure. And maybe take another 5 seconds or so if you haven't decided. How are things looking, Michelle?
Okay. All right. So this is kind of a tricky one. There's maybe more than one right answer here. So yes, if you are going to continue the oxaliplatin, you would definitely want to desensitize the person for future doses, because it is probably an IgE-mediated response, and it's just going to be at least as intense, if not worse, the next time she gets treated. Okay. However, the trick question was kind of that she's a metastatic patient. So I probably, because she's metastatic and it's not for cure, I probably wouldn't put the lady through a desensitization. Going forward, I would omit the oxaliplatin or switch her therapy is probably what I would be done, or what providers would typically do. All right. But yeah.
All right. Well, we'll move on to the next question. Thanks to everyone for answering that. And we have impressive numbers. We have over 175 people on today.
Wow, that's amazing.
Yeah.
Kudos to everyone getting their CE before December. All right, next slide. Okay. All right. So we're going to talk about chemotherapy-induced peripheral neuropathy. Okay, recommendations for prevention and treatment. So some agents, next slide. So some agents that are most usually associated with causing peripheral neuropathy would be, of course, our friends taxanes and platinums again, but also ginkgo alkaloids such as vincristine, vinblastine, vinorelbine, eribulin, which is a medicine used in certain types of metastatic breast cancer, or occasionally I've been seeing it used in sarcoma now, and then bortezomib and carfilzomib, which are primarily used in multiple myeloma. All right. So the American Society of Clinical Oncology, or ASCO, just put out a guideline update on chemotherapy-induced peripheral neuropathy this past July. Paclitaxel myalgias and arthralgias that are common within the couple days after infusions are reclassified as acute neuropathy. It might have actually been that way in 2014. I think we knew for a while that if people had these myalgias and arthralgias after like a taxane, that they were more prone to develop a peripheral neuropathy, but now they're being classified as an acute neuropathy. And that total chemotherapy exposure is the only recommended prevention strategy in this guideline, okay? So next slide. So, prevention. So not recommended or potentially harmful is acetyl L-carnitine, which I think was an infusion given. It was done with a drug that's not even approved in the United States, but it was known to cause peripheral neuropathy, and it showed that people who got that medicine were actually worse off, had more neuropathy than people who didn't. So yeah, we're not going to recommend that. And then the recommended in clinical trial, but requires more data, and this is per the guidelines, would be trying acupuncture, cryotherapy, and I need to make my slide bigger so I can read what I put down there. Compression therapy, exercise therapy, and something called GM1, or ganglioside monosialic acid, which I have never seen or heard of. Okay. Not recommended or no benefit found would be amitriptyline, which is a tricyclic antidepressant. Calcium and magnesium. We used to try to use this to prevent peripheral neuropathy from oxaliplatin. You give infusions of calcium and magnesium immediately before and immediately after the oxaliplatin dose. It's not recommended anymore. Sadly, gabapentins or pregabalin wasn't found to be helpful, nor omega-3 fatty acids, venlafaxine, vitamin B, or vitamin E. Okay, so we're going to concentrate on a couple of these things in here because, again, it's guidelines, so it's not perfect. Sometimes you have to do what you got to do for patients. So next slide. Okay. So while cryotherapy, which is keeping the hands and feet cold during chemotherapy administration, while that is not recommended outside of a clinical trial, because it can be kind of a time-consuming process, I think this is worthwhile. We've had patients do it at UNC, and I think most have not had any neuropathy because of it, which is pretty amazing. So there's a couple of different strategies. So Hanai et al. In 2018 had people using frozen gloves and socks, and patients were their own controls. Oh, next slide. Sorry, Tim. So the and that's amazing. And then like the READY trial in 2019 was published in Breast in December 2019. They just used crushed ice for cryotherapy on the hands and feet of breast patients receiving weekly paclitaxel times 12 doses. So 39 patients completed the trial with 19 in the cryotherapy group and 20 in the control group. The results, unfortunately, did not show a statistically significant difference between the study groups. The comment was that their control group had less neuropathy than is typically expected for that number of patients. But when they took the cryotherapy group and they compared it with the placebo control groups in this study and then 2 other studies, and then the cryotherapy arm in this study did show less neuropathy. So we definitely need to investigate this more. I think this is worthwhile because the crushed ice definitely falls into the won't hurt, might help category and is much more accessible way for patients to use cryotherapy. If you're going to use the frozen gloves and socks, they're expensive. They can be hard to find, to get the right size for you. So the just cost alone would prohibit so many people from being able to do this. And then the logistics of keeping multiple pairs cold enough while transporting to your infusion appointments would also make it like frustrating and impractical for many patients. So I think using crushed ice would be totally worthwhile. We've had patients doing it at our institution. And it seems anecdotally to be doing okay. So I'm excited. I hope that we get some more information. Somebody runs a trial on this and we get more information about how beneficial simply icing hands and feet with crushed ice in the infusion clinic can be. That is a very simple intervention with potentially really good benefits. All right. Okay. Not recommended yet, but I'm gonna, I would say why not? Why not do it? Okay, so ASCO treatment recommendations. All right. So as far as when people start getting in peripheral neuropathy, the provider, this is kind of tricky. They have to decide, all right, are we going to continue at full dose because you're curative intent and we want you to get enough treatment? Or when do we dose reduce to hopefully prevent you from developing permanent peripheral neuropathy? Because we don't want to cure someone's breast cancer and then they have painful neuropathy for the next 40 years, okay? So it's a balance always. So when people are done with their chemotherapy, they're no longer in therapy or no longer in therapy giving them, that could potentially give them peripheral neuropathy, they talk about treatment recommendations. So the only one that's given is for painful neuropathy, and that's to use duloxetine or Cymbalta for painful neuropathy, okay? Not recommended outside of clinical trials would be exercise therapy, acupuncture, scrambler therapy, which I had to look up. It's like a machine with electrodes placed around the area of pain, and it gives like a electric stimulation on the skin, kind of like a TENS unit that people might use, and meant to overwhelm pain information with non-pain information. Also, unfortunately, not recommended outside of clinical trial. We have our gabapentinoids here, gabapentin and pregabalin. There's a topical gel that involves baclofen, amitriptyline, plus minus ketamine. They put tricyclic antidepressants on here and oral cannabinoids. Okay. All right. Okay. So tricyclic antidepressants, why aren't they recommended? They got moved down from reasonable to try to not recommended, and that's because there isn't really enough evidence for them to treat chemotherapy-induced peripheral neuropathy, and there's no new clinical trials published since they last did this guideline update in 2014. Also, unfavorable side effects, drowsiness, irregular heart rate, confusion in older patients, and a lot of people getting treatment for breast cancer or GI cancer that will get oxaliplatin or paclitaxel typically tend to be older, so that's just something to consider there. And then GABA, next slide. I keep forgetting to tell you that. Okay, so gabapentinoids, which are gabapentin and pregabalin. All right, so the evidence for treating established chemotherapy-induced peripheral neuropathy is inconclusive. There's needs to be more clinical trials required before ASCO is going to routinely endorse it. And then, interestingly enough, though, some insurance companies require a failed trial of a gabapentinoid before they'll approve duloxetine. So you have to give them your patient gabapentin or pregabalin as a trial to see if it helps before the insurance is going to be like, okay, we'll pay for the duloxetine. Next slide. Okay. So this is a study done. It's published in 2 separate sites. It was done in Iran. Patients only received 6 weeks of treatment with either duloxetine or pregabalin. So pregabalin was 75 milligrams once a day times 1 week, and then bumped up to 150 milligrams twice daily. Ooh, I think I said that wrong. 75 milligrams twice daily at 5 weeks. So they were getting 150 milligrams a day. They only had 40 patients. And at the end, they found that the visual analog scale or VAS scores improved in 92.5% of patients. The visual analog scale is like a scale of 1 to 10 where the patient indicates on it by pointing is your 0 no pain, 10 the worst pain imaginable, that kind of scale, okay? And then duloxetine, they did 30 milligrams once daily times 1 week, and then 30 milligrams twice daily for the rest of the 5 weeks. And their visual analog scale scores and pain improved only in 38.1%. So it's, interestingly enough, 67% of the patients in the pregabalin group were receiving chemo when they started this, and then they finished at some point during the 6 weeks. And then 59% of the duloxetine group were receiving chemotherapy and finished at some point during the 6 weeks. So it's unknown how much improvement in the scores may be attributed to completing chemotherapy versus actually the medication intervention, okay? All right, next. Okay, so this is why they recommend duloxetine for painful chemotherapy-induced peripheral neuropathy. And if you've been doing oncology supportive care for a while, you would have come across this for a while ago. So, and this is published in the Journal of the American Medical Association, or JAMA, in 2013. It had 231 patients were randomized, and it showed that it was a double-blind placebo-controlled crossover. So each group got each treatment, placebo and then the duloxetine. You qualified for it if they had greater than or equal to grade 1 chemo-induced peripheral neuropathy and 4 out of 10, at least 4 out of 10 neuropathy-related pain. These are people who had been done with chemotherapy for at least 3 months, and the persistence had persisted that long. So usually we expect symptoms of neuropathy to improve once you stop giving people the chemotherapy, but this has, these patients had persisted for 3 months. And so what they did was they did duloxetine 30 milligrams once daily and then 60 milligrams once daily for 30 milligrams once daily for a week and then 60 milligrams once daily for 4 weeks. There was a 2-week washout period and they crossed over. And the duloxetine group did show an improvement in, they had reduced pain scores. And then depending on what interpretation you read, anywhere from 30 to, one group had 30% reduction in chemotherapy-induced pain, and another group maybe up to 50%. So that's pretty impressive, and that's why they recommend it for specifically painful neuropathy in people who are done with treatment. All right, poll everywhere question.
All right, here we go. So which medication is not usually associated with chemotherapy-induced peripheral neuropathy? You want to do the honors?
Oh, yes. So cisplatin, vinorelbine, docetaxel, or trastuzumab.
All right. And since we are running towards the end of our time, how did they do?
Good, yeah. Trastuzumab doesn't usually have neuropathy. Vinorelbine can have some, but it's less likely than the other vinca alkaloids. Okay. Cancer-related fatigue. Let's do it, guys. All right. So cancer-related fatigue is a distressing, persistent, subjective sense of physical, emotional, and or cognitive tiredness or exhaustion related to cancer or cancer treatment that is not proportional to recent activity and interferes with usual functioning. And this is the definition from the NCCN cancer-related fatigue guidelines, okay? So here's how it's evaluated: grade 1, fatigue relieved by rest; grade 2, fatigue not relieved by rest. It can impact your activities of daily living. Grade 3 greatly impacts your activities of daily living. So evaluating and assessing fatigue, they just said that this should be done for every patient on a regular basis. And this is just the simplest way they described it for adults on a scale of 1 to 10, with 0 is no fatigue and 10 is the worst fatigue you can imagine. So if somebody tells you a score between 0 and 3, it's none to mild; 4 to 6 moderate; 7 to 10 severe, or they can just use a description of how much fatigue they're experiencing: none, mild, moderate, or severe. Next one. Okay, so this is where if you are working in a supportive care role, especially nursing that sees the patient on a regular basis, you can really see how patients are doing over time with this. So you have to identify and treat the underlying causes that can impact fatigue. So it's multifactorial. You must assess and address each potential contributor for each patient. Fatigue can have a devastating effect on patients. It may make them rethink continuing treatment if they're unable to do activities they enjoy, such as spending time with loved ones or doing activities like golfing or something, or that are necessary for they need to continue to work to support their family or to keep their health insurance. So it's incredibly important that this gets addressed. So you need to talk about endocrine dysfunction like their thyroid or something, very important, especially in immunotherapy receiving patients. You need to address pain from the cancer that they're having. If someone's in pain, they're not going to be sleeping. They can't think about any other thing if they're in pain. Emotional distress. Are we like being worried about what's going to happen with their kids and their family and, finances and all sorts of activities like this. Addressing anemia, maybe they're running 7.9 hemoglobin. Perhaps they need a transfusion so they feel better from that. Maybe they have iron deficiency and they need an iron infusion. And then inadequate nutrition. There's so many ways that people might have inadequate nutrition. Next slide. Okay, so inadequate nutrition. We're so fortunate to have a couple of dietitians nutritionists at UNC that work specifically with the cancer patients. They are amazing. So some things to keep in mind, nausea or vomiting. Is it controlled? Is it not controlled? You really have to dig for this. Patients will not tell you. They will be at home puking and they won't say anything because they think that they're supposed to because it's cancer and that's what they saw on the TV show. So you need to let people know, like, no, that's not right. We have great medicines. Taste changes, dysplasia, I think is how you say that. Loss of appetite. Nothing tastes good. They don't want to eat. So they're not eating. So they're having fatigue from that. Constipation. They don't want to eat because they can't go to the bathroom, or diarrhea. They don't want to eat because every time they do, they run right to the bathroom. Mucositis. Big deal in our head and neck cancer patients, like with that radiation and chemo. Treating that mucositis, treating the pain from that, maybe they need a feeding tube for support. And then GERD. Some people don't want to eat because they have so much pain in their esophagus every time they eat something. Okay. Next slide. You have to treat the pain and emotional distress. It can cause insomnia. It can cause sleep interruptions, reduced activity. They're not doing things that's making them more tired. It can be side effects. Managing the side effects of medications, fatigue, like maybe you're giving them something to help with their gabapentin or pregabalin to help with their neuropathy that they're experiencing, but then they're so drowsy from that. So just making sure that you're assessing what could possibly be causing their fatigue. Next slide. For anemia and endocrine disturbances, check their hemoglobin and hematocrit, check and see if they need iron, check if maybe they need a transfusion, and that's usually managed pretty well, I think. It's pretty obvious. Hypothyroidism, if they're having that, either from immunotherapy or from another reason, you replace it. Are they having adrenal insufficiency? Another thing very common with immunotherapies, it needs to be addressed. Hypogonadism, like men on testosterone therapies like Lupron or Degaralex, hot flashes, interrupting their sleep, women and men both, interrupting sleep while they're going through treatment and stuff like that, just causing them, they can't function because this is going on all the time. So addressing those things. If you can control someone's hot flashes, then maybe they'll get better sleep. Maybe they'll feel better. Next slide. Non-pharmacological interventions. This is so important. This is low-hanging fruit. Anybody can make this intervention if you interact with the patient. And I'm surprised at how often this actually does help people. Talk to them about avoiding caffeine and nicotine in the late afternoon. Talk about a consistent sleep schedule if they're able to do that. Talk about avoiding bright lights in the evening. They should be dimming their lights, at least an hour beforehand. And talk about electronics and stopping those at least 30 minutes beforehand. This is especially important. Everyone's walking around. We all got our phone in our hand, looking up everything. Stop that at least 30 minutes beforehand. And then also eat light at night. Try to, you don't want to eat a big meal before you go to bed. This is super easy. And a lot of people don't know this. Some of it's common sense, some of it's just no one's ever discussed it with them. So it bears discussing this simple non-pharmacological intervention. Continued non-pharmacological interventions. Walk 30 minutes most days of the week for your physical activity. Cardiovascular endurance and resistant training, both important. There's studies that yoga at least twice weekly can be helpful for helping combat fatigue. You have to consider the patient-specific thing, though. Do they have bone metastases? That's going to put them at risk for a pathological fracture. That might dictate what they're able to do or not do as far as physical activity. Do they have low platelets or anemia? Like if they have anemia, their endurance might not be as good as it normally would be. If they have low platelets, obviously no contact, anything that you could fall down or have, you know, an injury. Have they had a recent surgery? If they've had a recent surgery, they might need to recover before they can resume activity. And then safety issues such as falling, like if they have peripheral neuropathy in their feet or something like that that can make them unsteady. And this is where you probably need to get physical therapy or occupational therapy involved in someone's care. Next, pharmacological interventions. Okay. Methylphenidate, which is like Ritalin, you could potentially use that in people that have either active treatment for cure, advanced cancer, and or end of life. So it's a potential intervention for all those areas. Corticosteroids, really only short-term use, really more advanced cancer, more toward the end of life, according to the guidelines. Nutritional supplements, inconclusive about if taking, you know, American ginseng or something might be helpful. Plus also supplements can interact badly with some chemotherapy, so you have to check that out. Modafinil, not recommended at this time, and then antidepressants not recommended. You want to treat someone's emotional distress, so you should be treating someone's depression, but you shouldn't be giving antidepressants. They talked about Paxil was studied and bupropion was studied, and you shouldn't be giving those specifically to treat fatigue. If you're treating someone's depression with those and that improves their fatigue, that's great. But, and then here's some methylphenidate. So use it with caution. First, you rule out and treat underlying causes. This is not your first go-to. You want to show, it shows improvement in fatigue compared to placebo. Good. And then optimal drug dosing in adults and cancer patients and older adults is not established. But in trials, they tried anywhere from 5 milligrams a day to 36 milligrams daily in trials. Probably reasonable to start with a methylphenidate 5 milligrams once daily starting dose. And the side effects are generally well tolerated, headache or nausea. So just gonna look out for that. Okay. Yeah. And then last one, Paul, we got through that one fast. All right. Which of these is least likely to contribute to cancer-related fatigue? Hormonal changes, inadequately controlled pain, daily exercise, low-calorie intake, or anemia?
All right, and again, in the interest of time, we'll say about another 5 seconds here. Thank you again for responding to these. Michelle, we seem to be really running strong on C with a close second on A. How did they do?
I would say least likely would be the daily exercise, yeah, because that's an intervention to actually improve fatigue. And then hormonal changes can definitely affect it just because, you know, people have, men have low testosterone, that's definitely going to affect their, you know, energy level. And then hot flashes that can happen in men and women as they're going through treatments that affect their hormones. That can definitely lead to some fatigue. All right, and then I had some questions on here. Shall I address those?
Yeah, and let me just put up the poll here. So we do have the poll for questions. You can go ahead and for our audience, please go ahead and submit those. We'll get to as many of those as we can, but we also recognize we need to let Dr. Gardiner go. So we'll, if we may, we'll forward some of those to you and let you respond to those and then share those online after the lecture.
I have a few minutes. Is that okay? Do you have a few minutes?
Yeah,
okay,
absolutely. Okay. That would be great. So yeah, if you want to take some of the ones that came in on the chat, and then we'll wait for some of the others to come in on the poll everywhere.
Okay, so the dysgeusia, that might not even be how you say it. I see it written all the time. I never use it because I'm not going to use that for a patient. No one knows what that means. But yeah, that's primarily taste changes. And if food doesn't taste good, people don't want to eat. And I've heard everything from if stuff tastes like metal from a platinum, you can tell them to use plastic utensils to help with that. If things taste like, I've heard everything tastes like dirt, everything tastes too sweet, you know, just trying to help people experiment with different seasonings and flavorings and, you know, to get some nutrition in. All right. I think a lot of people probably had to leave too because they only had budgeted till 1 o'clock, but
Yeah, here's one that did just come in. Is there a role for cannabinoids in alleviating side effects of chemotherapy?
Yeah, it's often where I've seen it used primarily is for like helping with appetite or as an adjunct to like if someone's having consistent nausea, and we've done our usual interventions with like, ondansetron or corticosteroid or whatever, if that's feasible for the patient. Not everyone can take those things. Then using cannabinoids for that definitely can help. A lot of our patients are using CBD oils for different things, but since those aren't approved in our state or FDA approved, I can't really, comment on that.
Right. All right. Well, thank you so much. Just a few things to wrap up here. We want to thank, as always, the North Carolina General Assembly for their generous support of the University Cancer Research Fund and the UNC Lineberger Comprehensive Cancer Center. We want to thank Mary King, Veneranda Obore, and John Powell for their tireless work on each and every one of these lectures. So thank you to each of them. We